We are good to go, ma'am.
Hello and welcome in today's nursing webinar session. Myself Shanti, and we are going to talk about the important life-saving medication known as the vasopressors group and its role in the emergency care setup. And having said so, let me welcome our expert panelist, Dr. Kiran Varma Garu, who is our HOD Emergency Medicine, Yashoda Hospitals from Somajiguda unit. I welcome you, sir, and I'm sure all your nurses will be very happy to have you in this session today.
Thank you, Ma. Thank you so much.
Yes, sir. And let me also welcome Mr. Abishek Murugan, who is our staff nurse, who is working since 2.5 years in emergency department from Somajiguda unit, Yashoda Hospital. I welcome you, Abhishek.
Yeah, good afternoon, ma'am. Good afternoon, sir. So, myself, Abishek. So, I'm working as a staff nurse in Yashoda Hospitals, Somajiguda. So, today we are here to discuss about the vasopressors.
Yes.
So, we have already...
Just a minute. We are glad to have you in this forum, Abhishek. And first insight we would like to understand from Dr. Varma Garu that like when we're talking about this medication, which is again life-threatening, saving medication, is nurses' current knowledge sufficient to treat patients in healthcare technology nowadays in this faster pace and this AI era? Your insight about this?
Yeah, it's a good question to kickstart our webinar. Thank you, Dr. Shanti, for that question. So with the new nurses and higher turnover rates, so they need to have ongoing training sessions or ongoing knowledge sharing programs like our webinar, which helps them a lot to improve their clinical knowledge and better skills. So which in turn helps to improve the better health services. So not only for our nurses, the nurses across the globe. So these kind of webinars would help you a lot.
So let us see what we have in the rest of the session. Abhishek, you can take over and you can start.
Yeah. So once again, good afternoon to everyone. So today we are here to discuss about vasopressors. So we have already aware about vasopressors. So we are practicing in our daily life, so especially in an emergency situation. So first we look into what is vasopressors. Vasopressors are the catecholamines, which are the type of medicines which causes the constriction of blood vessels and increases the blood pressure. So next we'll look into the functions of blood vessels and regulation of blood flow. So blood flow will be depend upon two scenarios, that like constriction of blood vessels and dilation of blood vessels. So constriction is nothing but the process of narrowing or thickening of blood vessels. So it makes the blood vessels smaller and it allows the blood flow as minimum to the particular part of the body or tissues. So in the slide, we can see the normal blood vessels and then dilated blood vessels and also a constricted blood vessels. So next thing is like dilation. Dilation of blood vessels is the process of widening or enlarging of the blood vessels. So in this situation, blood vessels will dilate so that diameter of the blood vessels will be increases. So it allows the more sufficient blood flow to the particular organ or tissue. So by that, it will give a rich, nutritious and oxygenated blood to the particular part of body.
Yes, having beautifully dealt the simpler, in a very simple way of anatomy about this, again, I would like to ask Dr. Varma Garu, like, we have seen in some scenarios when you give the order about the to start the vasopressor in the ER, do you find that nurses are able to initiate the infusion very promptly without any delays? Because I think you are the best who can experience nurses, interventions in treating these patients.
Yes. First thing, when you start our vasopressors, so thing is we we categorize the shocks. One is hypovolemic shock, then cardiogenic shock, septic shock. So if it is kind of septic shock, we start on the vasopressors immediately. So without waiting for a fluid response, that is one thing. Then the
Yes.
second entity of your question is then how? So what about our staff? Are they starting the vasopressor at the earliest on giving the instructions? Yes, our nurses are well trained in all kinds of techniques, everything. It includes initiation of vasopressors. So there was, in fact, there is no delay in initiation of vasopressors after giving our instructions.
Yes. So it is very glad that our nurses are, they are very much equipped with the technology and they know what they are supposed to do bedside. Yes. Over to you,
Next,
Abhishek. Yes.
when to use a vasopressor? So vasopressor will be used when there is a need to increase in blood pressure and maintain organ perfusion. So organ perfusion is nothing but when there is a need of providing and rich oxygen and nutritious blood supply to the vital organs which were displayed in the slide.
Yes. So yeah, go on.
So
yes,
then
one more
next
thing. How here I would like to ask even Dr. Varma Garu now, how critical is the time of vasopressor administration in preventing, because as Abhishek was mentioning that if we does not start this on time, then the patient may go into organ perfusion. So how critical about the timing of this? Maybe the nurses may not understand the criticality out of it because we have fresher nurses as well in the scenario. So your insight.
So regard to vasopressors, the time to initiate the vasopressor, yes, it has its potential benefits if you start the vasopressor at the earliest. So as I told you earlier, there are different kind of shock. So in the olden days, for septic shock, first we need to give fluids, then we need to wait for the response, then we used to start the vasopressors as per the old guidelines. But as per the recent guidelines, you can start the vasopressors along with the fluids, so that you are not going to waste the time. Then you are going to catch up the person who is in the critical period. So if you don't catch up with the time, we tend to lose the patient. It is likely to cause morbidity, mortality as well. So timing of initiation of vasopressors plays a vital role in saving persons with septic shock or sometimes like a cardiogenic shock and all. Yes.
So next we'll look into the uses of vasopressor in critical condition. So critical conditions such as hypotension, shock, vasodilatory shock, mainly especially in the septic shock, and also an cardiac arrest. So in cardiac arrest, majorly we'll use an adrenaline injection, adrenaline. So every shot will be given for 3 to 5 minutes. One shot of adrenaline has to be given.
So as we were talking a lot about the shock and life-threatening emergencies, are vasopressors always necessary in these conditions, as Abhishek is mentioning, which is rightly displayed here?
Yes. So it is kind of dilemma. There are many things. There are two schools of thoughts, whether to start the vasopressor, whether to start the fluids and all. As I told you earlier, if it is hypotensive shock, first you have to restore the fluids, then you have to go for the vasopressor. Vasopressor is the last sort of resort to treat with the hypotensive shock. When it comes to septic shock, yes, it is required. Then if it is a cardiogenic shock also, yes, it is very much required because we don't get more fluids in that conditions.
Yes.
So why it is very critical is you have to maintain the systolic blood pressure more than 90 at least. MAP should be more than 55 to maintain perfusion to the vital organs like brain, heart and lungs. So that is very, very essential to use this kind of vasopressors in selected conditions.
So next we'll see the clinical signs of shock. So already sir has explained, Dr. Varma sir has explained types of shock like cardiogenic, septic shock, hypolemic shock. So what are the clinical signs of shock? So by seeing these parameters like altered mental status. So in altered mental status, by discussing with a patient, by asking and questions with them, so we can come to know the mental status of the patient. So if it is altered, then it also includes in a signs of shock, and then cool and clammy skins, decreased urine output. So we all have already know about that. If patient is in shock, there won't be an urine output. So then like signs of organ dysfunction. So if patient is having an organ dysfunction, there will be an elevated lactate level and then metabolic acidosis also. So elevated lactate level is nothing but if an lactate level is more than 2 millimole per liter means it indicates lactate level is elevated. So then directly we'll come to know that patient has having an organ dysfunction.
So, sir, I think you would also acknowledge that these signs to be firstly not only by the doctors, even to be identified by the nurses and at emergency as well. So, what do you think that are they able to clinically identify that yes, these are the kinds of shock, and what is their role in treating this patient?
Yeah, I do admit, because our nurses not only treat the patient, so as we all know that they're all like an angels in the form of human beings. They not only treat the patient, but they know how to assess the person, then how to identify the clinical signs of a particular disease. Since we are talking about shock, they know how to identify the things at the earliest, like altered sensorium, cold clammy peripheries, feeble pulse, then tachycardia, then reduced urine output. They know variable altered mental status. So our nurses are they're intelligent. Sometimes being a doctor, we tend to skip certain things, but they do follow the protocols properly. Since they are there on the field, we are very happy for that. Sometimes we tend to miss. Sometimes they pick it up. Majority of the time, they pick the vital things. Let's say hypotension. There is hypotension, reduced urine output. Patient is going unconscious, semi-conscious. So they try to give us clues to treat a patient. So they not only treat the patients, they identify the things at the earliest to save the patient.
So we appreciate their effort because at the end,
true.
patient safety is important. Yes.
Oh, okay. So thank you for motivating us, sir. So then we'll go for an criteria to receive an vasopressor. So as an as we have to look for some certain criteria which kind of patient has to be received by vasopressor. It's like hemodynamical parameters. So hemodynamical parameters is nothing but patient vital signs. So in this condition, patient will have hypotensive, and then central venous pressure, and then third thing is like mean arterial pressure. Mean arterial pressure is nothing but the amount of cardiac output in each cycle. And then next thing will be like severity of illness. It depends upon the patient conditions. For example, if you are taking a patient with severe sepsis or septic shock, so there is no question about that. The patient is required an vasopressor to maintain their BP. And the next thing is like response to fluid resuscitation. So patient who requires a administration of fluid, so we have to go for administering in fluid, and also if they request an vasopressor, so we have to go for an vasopressor along with the administration of fluid also.
So the very core element and essential about the fluid resuscitation in the initial treatment of shock. So what is the golden thumb of rule in treating this status?
Yes, actually, fluid resuscitation shock is kind of a rare subject. See, when we see the patient in emergency department, we categorize, as I told you earlier, it might be hypotensive, cardiogenic, septic shock. For example, if it is a hypovolemic shock, it might be due to loss of water, it might be loss of blood and all. So if you take an example of RTA case with the polytrauma, hemorrhagic shock, we categorize the patient into class 1, class 2, class 3, class 4 hemorrhagic shock. So when you receive such kind of patient, we start with the fluids. We don't start the vasopressor initially. We start with the fluids because we need to start with the fluids only. Then based on response to the fluid resuscitation, we categorize again into 3 categories: fluid responders, transient responders, non-responders. Yes, initially BP was low, tachycardia, tachypnea was there. We are given the fluids. So with that BP improved, then we can call him as a fluid responder. Then second category, initially BP was 80. We started the fluid resuscitation. Then BP improved to 110. Then altered mental state improved. Tachycardia settled down. Tachypnea settled down. Improving the urine output for some period, for hardly about 10 to 15 minutes. Again, he is declining.
Yes.
He is going back to hypotensive. He is becoming hypotensive. Then altered sensor, reduced urine output. Then we can call it as a transient responders because he responded transiently for the fluid. Then non-responders. If you give 1 liter or 2 liters of fluid also, he will not improve in any ways, like tachycardia, then improving the urine output, then improving the sensorium, improving the BP. So we can categorize 3 groups like responders, transient responders, non-responders. That is one criteria. If these kind of scenarios are there, then we need to give the blood products. Then, other than last resort is vasopressors.
Yes.
But unlike the septic shock, first we need to restrict the fluids. As per the sepsis, surveying sepsis guidelines, we need to, doses of fluid is 30 ml per kg. For example, 60 kg a person, then we have to give at least 1800 ml of fluid bolus. Then you have to go with the vasopressors. It's like in old one, but in the as per newer guidelines, first you have to start the fluids, then vasopressors simultaneously.
Yes.
So then in case of cardiogenic shock, you have to restrict the fluid. The reason behind you giving doing fluid restriction is you have to maintain the intravascular volume. At the same time, you need to correct the cellular dehydration.
Yes.
The main concept is to correct the cellular dehydration. So for which we need to use crystallized, not the colloids, because crystallized will not stay in the vascular compartment. It will cross the vascular membrane, then it will go to the cellular, it will correct the cellular dehydration.
Yes.
But if you use colloids, since it has got large molecules, it will not cross the vascular membranes, it will not correct the cellular dehydration. Though it corrects the hypotension, but it will not correct the cellular dehydration. Our point of interest is not only to correct the hypotension, at the same time you have to correct the cellular dehydration. So fluid restriction plays a vital role in when you're dealing with certain kind of shocks. But at the same time, fluid is contraindicated in certain kind of shocks like cardiogenic shock.
Yes. So very beautiful insight about your this classification of when to start fluid. And I think automatically when cellular dehydration is corrected, automatically the capillary refill also will pick up, I guess.
Yes.
Yes.
True.
Yeah.
Then one thing I would like to add here, hemodynamic modeling. Just go back to previous slide. Hemodynamic parameters. Nowadays, we are not using central venous pressure very frequently.
Yes.
So now we are going with non-invasive technique like checking of IVs with the ultrasound. That is non-invasive. We can do multiple times. There are no radiation effects and all. So central venous pressure is not a good indicator nowadays. Most it is weaned off from our protocols as well. IVC and urine output, they are the best parameters.
Thank you for the corrections. I think, yes, viewers, please do take the corrections and...
No, it's not a correction, it's just update.
Yes. Thank you. Yeah.
Now we'll go for common vasopressors, which we are using in an emergency situation. So like adrenaline, noradrenaline, dopamine, phenylephrine, and then also vasopressin. So here we can see a double check. So it indicates that these all medicines comes under high alert medication. So we have to follow the high alert medication protocol. Like before giving a medicine, we have to check for a doctor's order, and then we have to cross check with the shift senior or shift in charge who is on the duty. And then before giving an administration, again we have to go and cross check with the medicine chart whether it is documented or not. And then before giving a medicine, we have to check for vitals. And then after giving a medicines, we have to check for vitals. And then after giving each and every medicines, we have to documentation the time of medicine given and then dosage of given medicine from our side also, not only from doctor side, from nurse's side also, we have to document.
Okay, so Abhishek, such infusions, will you also write the label, right?
Yeah.
On the infusion, we have a high risk label, right?
Yeah, for high alert medications, we have separate label, which will be in yellow color. So we'll write the dosage of medicines, high alert medications, which we are using, and then amount of dilution. That is like normal saline. Usually we'll go with normal saline. So how much normal saline we are taking, and then we'll mention the ml per hour, like time period it has to go, how many ml per hour it has to go. So according to that, we'll correct in an infusion form.
So these safety guidelines has to be practiced to improve the medication safety practices. And always remember, nurses, please do not do any harm to the patient, especially in the emergency scenario where everything is very, very fast. So here we got to understand we have to keep everything in order and then start the infusion. Yes. Yeah, you can carry on, Abhishek.
Now we'll go for an effective communication. So as a nurse, we know that how much importance that communication is plays a major role in healthcare sectors. So effective communication, like communication between doctors and nurses, and then communication between nurses to nurses, and communication between nurses to patient, and also it includes other healthcare workers. So by maintaining an effective communication, we can prevent an medication error, and by monitoring and proper monitoring of the patient will prevent the patient from getting their condition too sick. So we should avoid the inadequate monitoring of patients. And then another one thing is like documentation. So here we can see the documentation. Documentation is like whenever we are assessing or monitoring the patient, each and everything like vitals, their BP, everything we have to document it in a nurse's chart or a triage. And then another thing is like dilution. Dilution is like as per the protocol, we have to dilute the medicines. And then dosage. Dosage as per the doctor's order, we have to go for the dosages. And then start or stop time, increase and taper dose. Taper dose is nothing but weaning of medications.
Yes. Yeah, go forward.
Yeah. Next, we'll look into the calculation. So as a nurse, we already aware about this calculation. So calculation is nothing but infusion rate. Infusion rate is equal to volume to be infused in ml by time in a minute or hour according to the patient condition and then level of dosage and then duration of the medicines. We'll go for this fluid calculation. I think so. We all have already aware about this fluid calculation.
So here again, we would like to ask Dr. Kiran Garu, can you tell us where the ineffective communication happens between the clinical team? Maybe it is between doctor to a nurse or nurse to a nurse or nurse to the ICU nurse, in the situations of handover. So
when it comes to our healthcare setup, so communication plays a vital role. So this kind of miscommunication happens when there is no clear and timely communication.
yes,
When there is no clear and effective communication, then sometimes documentation.
yes,
See, here I will tell you one thing: communication of documentation, documentation of communication.
yes,
Whatever you are communicating, you have to document. That is communication of documentation.
yes,
Whatever you are documenting, communicate it. So documentation of communication. So when you do these two things, communication of documentation, documentation of communication, errors in the medical system will come down to a greater extent that it is something we could say it is negligible. So majority of the mistakes happen due to miscommunication. So that's why we need to empower our nurses in all the aspects, including communication.
because sometimes we get to see these kind of infusion, orders are given just verbal.
Given.
Yes.
Or verbal orders given,
Yes.
not documented.
Yes. Yes.
So there was a delay in initiation of drugs and all.
Yes.
Then sometimes we order, example, Edropin,
Yes.
instead of 1 mg, I will tell 10 mg. So out of something,
Yes.
my mind was somewhere else, I would order for 10 mg. So if they don't know, then they might have given 10 mg. This is lack of communication. There are no clear messages, clear communication.
So
Yes.
no hassle of nurses, you should ask. Only a 3-letter word called ask. Ask that will, solve all the problems. And you not to be scared. You can just ask your clinicians, y'all are just team. Please do ask and give the, interventions. Yeah.
Okay. Now we'll go for assessment and monitoring while patient is on vasopressors. So if a patient is in a vasopressors, we have to look into the hemodynamic parameters, which we have already discussed. And especially in that vitals, we have to check for an BP. So most frequent monitoring of BP has to be required here. And the next thing is fluid balance and urine output. And the next thing is like electrolytes level. So for the checking an electrolyte levels, we can go for an ABG. So which we can get a rapid report in our hand. So by that we can go and check for an electrolytes level. So next thing is like neurological status. So same as we have discussed before, like by asking and questions, we can come to know how mentally patients are stable or not. So because of by taking those kind of interactions, we can assess the neurological status. And then here also documentation. So here also documentation plays a vital role. So nurse's role is not only like assessing and monitoring. We have to document. Then if we are failed to document, there is no use of assessing and monitoring the patients. So each and every time, whichever we are assessing, we have to document at a same time only.
So here, I think this is a very important slide, Dr. Kiranji, and how frequently, when initially the patients are on these vasopressors, the hemodynamic status to be, monitored. How frequently do we follow some time period, or every 15 or every half an hour?
Yes. So thing is, when patient is hypotensive, we order for vasopressors. We started with the vasopressors. Now question is, how frequently you have to check the vitals, or how frequently you have to do the monitoring, hemodynamics monitoring. So this is kind of tricky question. See, if it is hemodynamic unstable, we start the vasopressors. We have to check the vitals at least once in 15 minutes.
Yes.
Then here I would like to request one thing: try to check it manually. If there is no invasive things like arterial lines and all, if it is non-invasive, try to check it manually. So when you do it on the monitor like NIBM, NIBP and all, things, no dynamics will get varied. So there will be differences when you compare with the manual things, plus or minus 10 or 20. For example, actual BP was around 90, but monitor was showing like 110. We thought that BP got improved, but in fact it was 90 only. So what I request everyone, so take little bit extra, little bit of extra, put your little extra effort to check the BP manually at least once in 15 to 20, 50 to 30 minutes till he becomes stabilized. Then once he stabilizes, though he is on vasopressors, then you can adjust the timings according to the patient condition. But initially, please try to check the vitals at a frequent merit gap is like 50 to 30 minutes. That would be better, what I feel.
Yes.
Yeah. Addressing infusion pump alarms. So we all have known about this infusion pump. So whenever we are getting entered into the ward or critical care areas, we used to get sound like beep sound. So it indicates something going wrong somewhere. So we have to point for that. We have to note that. We have to go and sort out the problem at the time only. So mostly that sound will be from infusion pump. So it indicates that. So as a nurse, we have to look for occlusion alarm, check for kicks in tubics, and then ensure IV site is patent and flushed. So in this IV site, so if we are securing a cannula or IJV or EJ, whatever it may be, so we have to keep on flushing the cannula for every half an hour to 1 hour duration, because it is not like that we are going and connecting the infusion pump and connecting that line to the IV lines and leaving it over. So sometime there might be a blood clot in the IV lines, so that the transfusion may get interrupted. So we have to flush that line before administering medicine. So after that only we have to start for the vasopressors. Otherwise, there is no use of starting in vasopression. Then there won't be any progress in a patient condition also. So next thing is like air in line alarms, then programming errors. So even though syringe pump is an like machine, so there might be a programming errors also. So as per a hospital protocol, so we have to send the infusion pump for a biomedical, and then we have to replace it again and again as per the time duration, as per the protocol of an hospital also.
Yeah, very well said, Abhishek. I think you have covered all the points. And here, whenever we used to go for rounds, and we get to see nurses whenever there's an alarm or beep. So nurses have this little common potency or bound that they just silent the alarm and then they continue working. So but here we always, yes. So the alarm is here to indicate that there's something wrong with the patient body, or of course from the patient, from the machine. So you got to check what is this about, as he was just mentioning that air in line, or the line is not patent, somewhere there's a kink or knot in the tube, or maybe the IV line or the the pressure line is under the cot side rails or whatever. So you got to see whenever the machine sends you alarm, whether it is a ventilator alarm or infusion alarm or monitor alarm, any kind of, even DVT pumps, you got to see, check, take some time, is understand, and then start. Yes.
Then another one thing I have to share is like, if a patient is in trauma, severe trauma, then there might be a hemorrhagic shock. So for that kind of patients, we'll go for a vasopressors and also an fluid. So in that time, so patient is in trauma, so that time we'll go for some MRI or CT scan or X-rays. So during that time, we have to take that syringe pump along with us also. So in that time, what mostly it will happen, no? So most of the syringe pumps, there won't be backups. So please make sure that every syringe pump is having a battery backup or not.
Yes, very, very true. And nowadays everything is inbuilt battery backup. Yeah. Okay.
So next we'll go for an contraindications. So for every medicines, there is an contraindications. We already know about that. So for vasopressors, the contraindications are like ischemic heart disease, peripheral vascular disease, uncontrolled hypertension, then severe cardiac dysfunction, and then arrhythmias. So arrhythmias is nothing but some abnormal rhythms of heart.
So I think you will also agree, Dr. Varma Garu, that these conditions will contraindicate the usage of vasopressor therapy. I think, and initially we got to settle
Yes,
the patients and
there are
then.
few things like there are no absolute contraindications. Majority of them like relative contraindications only.
Yes.
So example, if you take adrenaline, MI patient, it increase the oxygen consumption. So again, it worsens the ischemic heart disease. So that is one of the contraindications. Then when you think about vasopressin, especially vasopressin, you should think about peripheral vascular disease. When patient has a peripheral vascular disease, better not to start with the vasopressin. It worsens the peripheral vascular disease. Sometimes patient might develop gangrene.
Yes.
So that is one thing. Then before you initiate vasopressin, you should think about renal artery stenosis as well. Certain cases like renal artery stenosis, better to avoid vasopressins. So like then another case like inotropes and vasopressors, one of the cardiac dysfunctions, dopamine. Sometimes we start with the dopamine and that is the more arrhythmogenic when compared to other things. So better to avoid dopamine kind of things like vasopressors and inotropes. So these are the relative contraindications, but it's not like a absolute contraindication.
Absolute, yes. So we might consider this as a potential contraindication? Yes.
Might.
Yes.
Exactly, we can't say 100%, but up to 5 to 10%.
And now, role of thermoregulation. So thermoregulation is nothing but maintaining a body temperature in a normal level. So maintaining the proper thermoregulation is crucial to prevent complications such as hypothermia or hypothermia. So hypo or hyper, whatever it may be. So patient may fall into both hypo or hyper. According to that condition, patient will go to the thermoregulations. And then next thing is avoid overcooling. So we should avoid overcooling of the patient. So already patient will be in hypothermia. So what, especially in ICUs, will be having ACs. So ACs, we won't mind about that ACs. So patient is already in hypothermia. So that AC, what it will do, still it will make the patient body cool. So still patient will go for a severe hypothermia. So that will lead to some other complication, which will still get the patient condition worsen. So we should avoid the overcooling of patient also. And the next thing is like considering sedation and analgesia. So sedation is nothing but if some patients, they won't cooperate for us. So whatever we are giving in medicines, they'll refuse and then they won't keep, not at all, they are being in quiet. So they'll do some activities, they'll remove the IV lines. So for such kind of patients, for preventing them, we should go for some sedation. So we have for making them to sedate. So and then another thing is like analgesia. Analgesia is nothing but painkillers. So patient like with the trauma patient, we will go for painkillers. Along with the painkillers, we can reduce their pain so that patient will be like comfortable. So we should consider for the sedation and analgesia.
Yeah. So here again, the role of thermoregulation is very important. And what are the, potential risk associated if at all the thermoregulation is inadequately maintained, Dr. Kiranji?
Yes, thermoregulation is the important aspect when you are dealing with a patient in shock. So there is a term called lethal trait. So one of the entity is hypotension. So hypothermia, acidosis, and coagulopathy.
Yes.
So these are the lethal traits. So hypothermia. So better to avoid the hypothermia. So because it leads to coagulation dysfunction, then coagulation cascade will get affected. Then sometimes it leads to clotting abnormalities as well.
Yes.
So that is a thermoregulation. Then we need to avoid the hyperthermia as well.
Yes.
So both are contrasts to the patient. So our body is designed in such a way that our functions will work at proper at the range of temperature from so and so. If it is too low, it is too high, it doesn't work. So it plays a crucial role when you are titrating your vasopressors. It also helps in improving the patient outcome as well. So think about thermoregulation.
Yeah, I think that was a very beautiful session, and we have come to the end of the session. Now, the conclusion, or in the nutshell, what we have for the nurses are like, especially those nurses who are working in ER, ICU ward, should familiarize with the inventory, inventory check. Actually, sometimes in the emergency scenario, we do not know where the things are. We have got a very massive crash cart. I think, yes, everybody should know how to manage the inventory and the familiarization of where what is kept so that you can facilitate when in times of real-time emergency. So it was very productive and very, discussive session by even also Mr. Abhishek and Dr. Varma Garu, both from one team. And I thank you for having you here, both of you, and we end the session.
Thank you, Dr. Shanta, for giving us opportunity. Thank you, Yashoda Hospital Management. So for creating such a great platform to share our knowledge and to percolate the knowledge into our nursing fraternity, which in turn helps to improve our health services.
Yes.
Thank you so much.
I would like to thank to my sergeant brother. So he has given me this opportunity. So I'd like to thank sergeant brother. So thank you, brother.
Thank you.
Thank you.